Hello and welcome to my channel Ace Your MRCP. I am Dr. Aparajita Roy, and through this channel I bring to you exclusive tips and tricks that will help you pass your MRCP in the very first attempt. Now today's video is very special as today I will talk about Fundus examination for your Station 5 PACES exam. In this video I will talk about how to correctly guess the diagnosis even before you have physically done an ophthalmoscopic examination. Now I have done a separate video on ophthalmoscopy. Please watch both these videos together to understand the nitty-gritties of fundus examination for Station 5 in PACES. If you are someone who struggles with ophthalmoscopy and feels anxious about what you would do if you are asked to do a fundus examination in your PACES, then this video is for you. Please watch till the end to understand how to arrive at a correct diagnosis even without being an expert in fundus examination. Now please understand that in the scope of this video, I will not be able to teach you how to do a fundoscopic examination. That you'll have to learn by visiting your friends in the eye department. However, here you will get a clear idea as to how step by step reach at a diagnosis if you are asked to do a fundus examination in Station 5 in PACES. Now let's look at the common cases that you can expect as a fundus examination station. First and foremost, retinitis pigmentosa. This is a diagnosis that can be very well arrived at by history and history itself. Focus on three main parts of history. Number one, night blindness, which is the very common presentation of retinitis pigmentosa. Number two, loss of peripheral vision. Now, your question stem may say that this patient has recently had a road traffic accident or this patient has history of bumping into things. Don't be fooled by this question stem. This is not pituitary macroadenoma. This is tunnel vision, as is seen in retinitis pigmentosa. The third point that you have to elicit to arrive correctly at a diagnosis of retinitis pigmentosa is family history. In order to gain more marks, try and elicit other signs and symptoms associated with systemic features of retinitis pigmentosa like polydactyly, sensorineural hearing loss, hypogonadism, obesity, skin changes, etc. By eliciting these 3 points, even before you have started your examination, you can correctly guess that this is retinitis pigmentosa. Identifying retinitis pigmentosa in fundus examination is quite easy. Now, be rest assured, even if you haven't seen retinitis pigmentosa before, it is actually very easy to identify on a fundus examination. It looks exactly like it is shown in the picture. You can see bony spicule-like hyperpigmentation bilaterally in the retina. It will be easier for you to see in the real exam where the patient's pupil will be dilated, and you can also ask the examiners to dim the light of the room. Now let's talk about another common diagnosis that you can expect in Station 5, that is optic atrophy. You can commonly get optic atrophy in multiple sclerosis or anterior ischemic optic neuropathy, or rarely in chronic glaucoma. The patient will give you a history of painless progressive loss of vision. In case of multiple sclerosis, the patient will give history suggestive of repeated optic neuritis. You can also ask the patient when was the last time you were seen by an ophthalmologist or an eye doctor and what exact follow-up did he want. Now, after the history, even before doing your fundus examination, by doing a normal eye examination, you can get valuable clues whether the patient has underlying optic atrophy. First and foremost, the patient will have central scotoma. Number two, the patient will also have red desaturation. Both of these findings can easily be elicited by a red hat pin during your visual field examination. The patient will also have loss of direct light reflex and preserved consensual light reflex. In early cases, the patient will also have relative apparent pupillary defect. All these findings, if correctly elicited, will lead you towards the diagnosis of optic atrophy. When you pick up your ophthalmoscope, you can expect to find pale grey optic disc with blurred margins. Do not confuse this with papilledema. This is a common differential for optic atrophy. Papilledema will be bilateral whereas optic atrophy can be unilateral or bilateral both. However, in PACES, papilledema patients are rare because papilledema is usually an medical emergency and will not feature in your PACES examination. Let's talk about diabetes next. If you get a patient of diabetic peripheral neuropathy in your Station 5, you will be expected to do fundus examination. You will notice that there is an ophthalmoscope placed right next to the patient. That is your cue that the patient might have some underlying fundus changes. But don't be anxious. Approach the patient step by step. So start asking the patient whether the patient has any visual loss symptoms. Whether they are central, like for example the patient is finding it difficult to read, or whether they are peripheral. If the patient says that he has central loss of vision, then that is an important clue that the patient has underlying macular disease. Ask the patient whether these changes have been sudden in onset or gradual. If there is history of sudden visual loss, that might point towards a diagnosis of vitreous hemorrhage. If the changes have been more gradual, it could be simple case of cataract or osmotic changes in the lens. Also ask the patient how frequently does he see his ophthalmologist. If the patient says that I see my ophthalmologist annually, then we can be rest assured that the patient just has pre-proliferative changes and does not have any hemorrhage or any clinically significant macular edema. However, if the patient says that I see my ophthalmologist very frequently, then that is a pointer towards that the patient might have underlying proliferative diabetic retinopathy. The next question to ask the patient is whether he has ever had laser therapy done in his eyes, whether that was just once or more than once. All these questions are important clues towards the underlying condition. If the patient says that I have had laser done but only once, then that can be a pointer towards focal laser therapy that's done in macular disease. If the patient says that I have had repeated laser treatment, then you can be rest assured that the patient has an underlying proliferative diabetic retinopathy. Remember, even in our day-to-day clinical practice, we leave ophthalmoscopy to the expert. And if we suspect that the patient does have underlying retinopathy, we refer the patient to the ophthalmology department. This is exactly what would be expected of you in the PACES exam. Please be rest assured that the examiners are not looking for experts in ophthalmoscopy. However, in a patient where there is suspected underlying diabetic retinopathy, you will have to A. collect relevant history, B. make a reasonable effort to do the examination, and C. must refer the patient to ophthalmology department. If you ask these questions step by step as we have discussed in video, that will definitely impress your examiners and will help you score top marks in fundus examination. That's it for today, guys. Please let me know how you find this video and whether it helped you clear some concepts in fundus examination for you. Please don't forget to like, share and subscribe to my channel. Till then, keep studying, stay safe and ace your MRCP.